Good evening, friends. Today, our guest speaker is Dr. Sergio Gerard from New York. He will be lecturing on Myeloma 2022. What have we learned since the pandemic? This webinar is brought to you by Mumbai Hematology Group. It is supported by Janssen and Pharma firm and managed by Mice Ideas. I thank Team Janssen and Team Pharma firm, Rajesh Kalpesh and Team Mice Ideas, Executive Committee of Mumbai Hematology Group, of course, our guest speaker, Dr. Sergio from New York, all our discussants who are eminent hematologists or medical oncologists from India, and you participants for registering and sparing your Saturday evening. Today, we have registration from 15 countries, and it's not only Asia, but also from Europe, Africa, Australia, US, and Canada. Tomorrow morning at 11:30 a.m. Indian Standard Time, we have the next webinar on sickle thalassemia, a deceptive disease, and Dr. Antonio Piga from Italy is our speaker. Discussants today, we have a galaxy of fantastic faculty to interact with our speaker, Dr. Sergio today, Dr. Sharad Damodar from Bangalore, Dr. Monica from Bangalore, Dr. Srijesh from Chandigarh, Dr. Dipesh from Chandigarh, Dr. Aditya from Chandigarh, Dr. Dharma from New Delhi, Dr. Meher Lakshmi from Hyderabad, Dr. Vindhya from Hyderabad, Dr. Yashwant from Raipur, Dr. Abhishek from Ahmedabad, Ankit from Ahmedabad, Aruj from Ahmedabad, Dr. Abhay Bhave from Mumbai, Dr. Chandrakala from Mumbai, Dr. Srinath from Mumbai, Deepanjan from Mumbai, Dr. Darshana from Mumbai. It's my pleasure to again introduce today Dr. Sergio. He has been our speaker in past. We've enjoyed his teaching. He's Deputy Head, Division of Hematological Malignancies at Sloan, Professor of Medicine at Cornell. He received his medical degree from University Central Venezuela. He completed residency at Good Samaritan Hospital, fellowship at the University of Texas at MD Anderson. In addition to his positions at Sloan, he is Professor of Medicine at Cornell and Melvin Burnell Family Chair in Myeloma Research. He is an active member of the several professional societies such as ASH, ASCO, North American Society of Blood and Marrow Transplant, International Society of Hematology and Graft Engineering, and the Gerontological Society of America. Previously served as chairperson on the executive board of the Center for International Blood and Marrow Transplant Research and the steering committee of the Blood and Marrow Transplant Clinical Trials Network. Past president of ASBMT, a board-certified hematologist oncologist whose clinical practice and research focuses on stem cell transplantation for patients with blood disorders. He, with his colleagues, pioneered the use of reduced intensity conditioning regimen for older and more debilitated patients with blood cancers. His research has examined the use of T-cell depletion technique to dramatically reduce the risk of graft versus host disease. It's published and presented extensively on these subjects. Additionally, he has served as the principal investigator for several clinical trials that examine new treatment approaches for myeloma and other blood cancers that aim to reduce symptom burden and improve treatment tolerability. It's my pleasure to invite him to deliver his talk on Myeloma 2022, What Have We Learned Since the Pandemic? Thank you. Over to you, sir.
Thank you very much, Dr. Mohan, for the kind invitation, and thank you to the Mumbai Hematology Group for spending their Saturday night. I don't know if I could ever have so many people here on a Saturday night, so I'm truly honored and privileged. So before we begin, please advise me if you can hear me okay and you can see my screen okay.
Yes, sir.
Perfect. These are my disclosures. And the most important conflict of interest I have, I'm a transplant. So today I want to talk to you about the current status of myeloma therapy in regards to induction, consolidation, and maintenance. And then at the end of the talk, just give you a flavor of what we have learned with COVID on transplant and the impact it has had on transplant therapy in the United States, with particular emphasis on what happened in New York in March, April, and May of the first year of the pandemic, 2020. So let's begin with a presentation. A 65-year-old with kappa light chain myeloma diagnosed in January of 2019. It's found with 5 grams of proteinuria, an albumin of 3.9, a beta-2m of 5.7, a creatinine of 1.7, and a very high kappa lambda ratio. Bone marrow biopsy shows 80%, 25% plasma cells with no FISH abnormalities consistent with high-risk disease. She has extensive lytic bone lesions. She's a diabetic on metformin, but has no history of coronary artery disease or other comorbidities. So the first order of business for us is to risk stratify patients with myeloma. This is a patient with a high beta-2m and thus is an ISS stage 3 and would automatically be considered as high-risk disease. And this is important as we think about how we now plan induction in modern times, because high-risk disease, as you can see, with standard triple drug therapy, even with an autologous transplant, these patients have an average life expectancy, an average remission duration of less than 3 years, and an average life expectancy of less than 5 years. So what are the common definitions for high-risk disease? The characteristics that predicts a high rate of disease progression and death despite optimal therapy. As this patient, ISS stage 3 is by definition high-risk disease. Plasma cell leukemia is actually, the definition is changing, and now any presence of plasma cells in peripheral blood would be considered plasma cell leukemia, and that's going to change in the next couple of months officially by the International Myeloma Working Group. There are specific chromosomal abnormalities that we now recognize that are associated with worse prognosis with standard triple drug therapy induction, autologous transplant, and lenalidomide maintenance. That is deletion of 17p, several group of patients with 14q3t translocations, such as 414, 1416, and 1420. Although deletion 13 by FISH can be seen by FISH studies, it is not a negative prognostic factor. However, when deletion 13 is seen during conventional cytogenetic analysis, that is a bad prognostic factor, but it generally means that these plasma cells can grow in the cytogenetic plate and therefore probably do not need stroma to be able to grow and multiply. More recently, we've identified that amplifications of 1q21 as well as 1p deletion also increase the risk of myeloma progression. So we're currently recommending that all patients have the following tests done in their myeloma panel at the time of initial diagnosis or at the time of relapse. And you can see those there. I'm not going to repeat this. And obviously, regardless of how a patient presented, any patient relapsing within 2 years of primary therapy is high risk, regardless of cytogenetics or stage. So I think one of the main things that we've been focusing on over the last couple of years with randomized trials is how do we optimize induction? We'll talk about the continued role of consolidation with high-dose melphalan and autologous transplant, and we'll mention a little bit about what's happening in the maintenance space. So what have the randomized trials taught us? So I think this that was presented in ASCO a couple of years ago was a surprise for many of us. In this endurance trial that was performed by the ECOG cooperative group and presented by Professor Sajid Kumar, carfilzomib, lenalidomide, and dexamethasone was compared to bortezomib, lenalidomide, dexamethasone in initially newly diagnosed myeloma patients. This is the schema. And what was surprising to all of us, and this have held in follow-up studies, is that the progression-free survival for patients receiving KRD was no different than for patients receiving RVD. And we all expected that patients receiving carfilzomib induction, because carfilzomib is a superior proteasome inhibitor, would have better outcomes. Now, it is important to note with this study, one, that a significant group of patients went on to transplant and those were censored. So it may be that KRD may be better in patients who undergo transplant compared to RVD. And two, very few patients had high-risk disease. So that this lack of difference between KRD and RVD it cannot be translated into patients with high-risk disease because they were not appropriately represented in this study. I think of most interest to us is the follow-up of the Forte trial that was presented by Dr. Francesca Gay. Just to remind you, in this trial, again, using carfilzomib as the proteasome inhibitor in combination with either an IMiD, lenalidomide, or an alkylator, cyclophosphamide. And then two questions were being asked. In the context of a proteasome inhibitor such as carfilzomib, should it be combined with an alkylator, i.e. cyclophosphamide, or should it be combined with an IMiD, i.e. lenalidomide? And in the context of carfilzomib, lenalidomide, dexamethasone, what is the contribution of high-dose melphalan? So you can see this was a 3-arm randomized trial, and there was a second randomization in which patients were randomized to either lenalidomide alone maintenance until progression, or lenalidomide carfilzomib given at a dose of 36 milligram per meter squares on days 1 and 2 of every month, and then on 15 and 16. So given twice a month instead of 3 times a month, as is usually given. Our first surprise with this study is that there was no difference in regards to response rate in patients who had 12 cycles of KRD versus those who had KRD for 4 cycles of transplant and KRD consolidation for 4 cycles. However, as you can see later on, there was a significant difference in progression-free survival for those patients who received an autologous transplant in the context of KRD induction. 78% of the patients remained progression-free at 3 years, versus 66% for those who received 12 cycles of KRD. The reason for this difference is there was a significant benefit in regards to sustained measurable residual disease negativity at the level of 10 to the minus 5 for patients who received the high-dose melphalan. That was 68% of the patients achieved sustained MRD negativity versus only 54% for those that received KRD 12. And as was shown in the bortezomib inductions, a proteasome inhibitor is better combined with an IMiD than with an alkylator. What's most interesting is that this study did have significant amount of patients with high-risk disease. And the benefit of KRD transplant was significant in patients with both standard and high-risk disease, as well for both compared to both KCD induction and KRD 12. And you see the hazard ratios there. So if 3 drugs is good, what about 4 drugs? So the addition of daratumumab, the CD38 monoclonal antibody, has been studied in 2 large studies. The largest of them, the Cassiopeia study, has been published and presented in multiple meetings. In this study, bortezomib, thalidomide, dexamethasone, which is the traditional induction therapy given in many countries across the world because thalidomide is easily available and fairly accessible, was combined with daratumumab, and patients received an autologous transplant. And then there was a second randomization to observation until progressive disease or to daratumumab maintenance. And as one would expect, the 4-drug combination was associated with a significant increase in major response rates. 43% of patients achieving a stringent CR after all treatments, versus only 33% for patients receiving the 3-drug combination. Moreover, there was a significant benefit in progression-free survival for patients receiving the 4-drug combination, as opposed to the patients receiving only the 3-drug combination. And there was particularly an impact for patients who failed to achieve a major response. The other randomized trial was performed in America, and again, also recently presented and published. This is the Griffin trial, in which daratumumab was combined with bortezomib, lenalidomide, dexamethasone in the doses that you see on the slide, and compared to the traditional RVD induction. As the other studies, patients received 4 cycles of induction, underwent stem cell collection, and then immediately underwent high-dose melphalan stem cell transplantation, and then followed by 2 more cycles of consolidation and a total of 25 cycles of maintenance, with the randomization being daratumumab given once a month or every 8 weeks, and then with lenalidomide given 10 milligrams a day or escalated to 15 milligrams a day after cycle 10 versus lenalidomide alone. And as you can see again, as was seen with the Cassiopeia trial, significant benefit in regards to major response rates. 81% of the patients achieved either a CR or a stringent CR versus only 63% achieved a stringent CR versus 47%, and 60% achieved either a CR or a stringent CR versus 81% in the patients that received the 4-drug combination. The other main benefit in what we're seeing is that patients achieving a sustained measurable residual disease negativity at 10 to the -5 have a significant benefit in regards to disease control. Here, the 4-drug combination showed that 30% of the patients could achieve MRD negativity that lasted for at least a year versus only 2 to 3% in the patients that received the 3-drug combination. The study is still early and it has yet to show a benefit in regards to overall survival, but the curves are starting to separate, showing a potential benefit for the 4-drug combination. One of the things I want you to note is that as opposed to the traditional studies, which I will compare later on, you can see that the failure rate for the first 2 years in the patients receiving the 4-drug combination is less than 6%. And actually, for the first 3 years, less than 10% of the patients have failed. And this is really different from what we see with the 3-drug combination in addition to an autologous transplant. So what's the optimal induction that we've learned? Probably 4 to 6 cycles of a quadruplet with a CD38 monoclonal antibody, a PI, and imminent steroids. In the US, Dara-KRD is starting to become the standard. Dara-KRD versus Dara-RVD is being explored. In Europe, Dara-VTD is being explored because it was the Cassiopeia trial was done. It is important to collect after 4 cycles in patients receiving 4-drug combinations because in data that I have not shown, exposure to the 4-drug combination does affect stem cell collection and yields. You need to assess patients for the risk of infection. They all need viral prophylaxis. In patients who are severely immune compromised, PCP prophylaxis should be considered. Older patients, we should consider attenuating the doses of steroids and thinking about using antibiotic prophylaxis. For patients that are non-transplant eligible based on the MAIA trial, Dara-based induction should be seriously considered. And in all types of situations, depth of response matters. So with these drugs, what is the role of hematopoietic cell transplantation? So I just want to show you a couple of long-term follow-ups. This is the French study in which VRD transplant was compared to VRD alone. And what I want to show you is that in this study, progression-free survival was significantly better for patients who underwent an autologous transplant, even when you compare it to patients who had achieved an MRD negative state with RVD. And that's because the MRD negativity rate in the transplant arm is significantly higher and the depth of response is probably bigger. So at least in this, and this is now long-term follow-up with more than 89 months. I want to show you something which I think has been very interesting, was presented this year at ASH by Dr. Susan Ball from Dr. Costa's group in Alabama. So what she wanted to show is using a very, very sensitive next generation sequencing technique, whether you could show that high dose melphalan autologous transplant deepened the response. And this is what they call the master trial, in which patients received Dara-KRD induction for 6 cycles. They underwent an autologous transplant, and then they had a response adapted treatment. For patients who had 2 measurements of MRD negativity, they would stop treatment. The treatment was relatively well tolerated. There were 2 deaths before day 100. One was metapneumovirus pneumonia, and the other one was sudden death. And there was an ultra high risk patient with more than 2 cytogenetic abnormalities, which had progression by day 100. So you can see from the International Myeloma Working Group response that most patients had further deepening of the response after, so you have the stringent CR rate went from 34% to 66%, which really goes because the VGPRs, many of them went on to convert to complete remission rates. And very few patients progressed between the cycles of induction and the transplant. What's even more interesting and what they showed was that patients with 2 high-risk cytogenetic abnormalities had a deepening of their response to a greater degree than patients who had no cytogenetic abnormalities or only one cytogenetic abnormalities. Once again, suggesting that high-dose melphalan may have even a bigger impact on patients with high-risk disease in the context of 4-drug induction treatment. And this is the next generation sequencing data. And what you want to show is that you were able to get you double the amount of patients who had an MRD negativity rate of 10 to the minus 5 from 33% to 67%, and fourfold the amount of patients who had an MRD negativity rate of 10 to the minus 6. So what this suggests is that despite having major responses to induction, those responses can continue to be deepened in the context of high-dose melphalan autologous transplant. So I think one of the things that we're starting to learn with the changes in induction therapy is that relapse patients will be significantly different. So how we treat a patient who had a DARA-based induction and is relapsing on DARA and lenalidomide maintenance will be totally different to the way we're treating patients now who are on lenalidomide maintenance. So I've divided patients into patients who relapse into those who are not triple refractory and pent exposed, and those patients should be treated depending on their prior exposures. Non-transplant eligible frail patients, we can consider pomalidomide, elotuzumab, or repeat prior combos if they worked. For patients who are transplant eligible or in good risk, serious consideration should be taken for a second autologous transplant, and even an allogeneic transplant in younger patients with short remissions. Needless to say, all these patients should be offered clinical trials. Currently, in the United States, we have BCMA-targeted therapy. Belantamab has become commercially available, with the main side effects being ocular toxicities. We have ide-cel, which is the first commercially available CAR T-cell targeting BCMA, and hopefully this year we'll also obtain cilta-cel, which is another BCMA-targeted therapy. Next year, we're expecting that we will have a variety of bispecific antibodies targeting different surface proteins, BCMA, GPRC5, and FHRCR5. So in summary, we are now at the dawn of a new era in myeloma therapy. We have strategies that can now impact the major causes of treatment failure, relapse, infections, and toxicities. The way forward will require more personalized approaches to develop the optimal strategy for each patient and their myeloma. Only prospective trials and well-curated large data sets will allow us to develop the knowledge necessary to perform such transplants. We need to substitute our current triple P transplants where we push the drugs, pour the cells, and pray that it all works out, to modern triple P strategies of precise, personalized, and predictable transplant. Dose-intense therapy will continue to be an important component of a curative strategy for myeloma with both autologous and allogeneic transplant. I actually think that long-term disease control should be possible for a majority of patients with myeloma with the rational combination of current available therapies. Problem will be, and we didn't go into this data, is how can we get these drugs to all patients who need these drugs, particularly in countries like India or in Latin America. So I want to change gears a little bit and talk about the impact of COVID on recipients of transplant and CAR T cells. I just want to show you what the streets of New York looked like in April of 2020 when, the day we went into complete lockdown on March 13th, 2020. This is what the streets looked like in New York City on April. Lots of papers have come out about what the impact of COVID, of the pandemic, has been on different types of cellular therapies. And basically, two large consortiums were created. One is the ASH Research Collaborative, and the other one is the CIBMTR. The ASH Research Consortium were collected data on more than almost 1,000 patients across the world. And with those, we looked at, how many of them had received cellular therapy prior to their COVID-19 diagnosis. And you can see here that approximately almost 50 patients had received an allogeneic transplant, almost 80 patients had received an autologous transplant, and 10 patients have received CAR T cells. Although not there was definitely an increased risk of mortality, as you can see in red. 7 of the patients post-allogeneic transplant died. 7 of the autologous patients died. Now, remind you, many of these patients did not necessarily die from COVID. Some of them died from their active malignancy, and the research collaborative was not easy to dissect that data. Dr. Wood published the paper from the ASH Research Collaborative in Blood Advances, and I recommend that you look at that paper. And anyway, the thing is that in patients with blood cancers, 42% of the patients with moderate or severe COVID died from that complication. Remind you that at that time, we did not have monoclonal antibodies. Dexamethasone was not routinely used for patients early in the pandemic because there was the concern that it could make the infection worse. And we now know that a lot of the pulmonary toxicity of COVID is really an inflammatory reaction that can respond to steroid therapy. The other thing that we learned that immediately many of us in the transplant field required, the NMDP also required, that all products be cryopreserved before patients received conditioning regimen. The rationale for that is that we did not want to condition a patient with myeloablative therapy and then find out that the donor had contracted COVID and was not able to be collected. So it was felt that for the safety of the patient, it would be important to cryopreserve the cells prior to conditioning. And what I show in this paper from Su et al., the graft cryopreservation did have some impact on outcomes, but it was not, bone marrow was not affected. A match-related peripheral blood stem cell seemed to have a slight increase in non-relapse mortality. Those achieved statistical significance. But again, I think if we had to do it all over again, we would continue to do it. There is conflicting data, I might say, because there is other data that show that there is no impact. But I think it's important to note that we really had no choice in the events of in the presence of the pandemic at the time as it was. And I think the other thing that's important to impact is that these groups were not necessarily comparable, right? This was not a randomized trial. Dr. Gunjan Shah and Dr. Susan DeWolf did a deep dive in our patients who received hematopoietic cell transplantation. So they had 77 patients that were diagnosed during the first quarter of the pandemic. Half of the patients had autologous transplant, another half had allogeneic transplant, and 5 patients had undergone a CAR T cell. And you can see here, most of the patients were within the first year of having received their cellular therapy. And then you can see in the other types of diagnosis, most of the patients with acute leukemia or aggressive lymphomas. These are the patient's characteristics, which are standard. So as you can see here at that time, again, we're talking about the beginning of the pandemic. Most of the patients were presenting with fever, cough, severe fatigue, and myalgias. And some of the patients were presenting with confusion and severe shortness of breath. At that time, we did not have any COVID-specific therapies. Patients were receiving a smattering of things. Most patients did not receive steroids, and some patients received IVIG, tocilizumab, and some of the patients were able to participate in a clinical trial. More than half of the patients received some form of treatment. So as you can see, 40% of the patients had mild COVID and they were not admitted, but 60% of the patients had COVID that was severe enough that required admission. 45% of the patients did not require any oxygen supplementation, which means that 55% of the patients, 55% of the patients required some form of oxygen supplementation. So in the end, there were 14 deaths, that's 18%, 41% of patients admitted, but 21% if they were admitted and their malignancy was in remission. There was no worsening of graft versus host disease, no increase in dialysis. 2 patients had DVTs, but there were no major strokes. One of the interesting things that we saw is that all patients developed severe lymphopenia at the time of COVID infection, which eventually recovered. And then lymphopenia actually affected all types of T cells, CD8s and CD4s. Of note, and what we always thought was very interesting is despite these lymphopenias, patients develop some form of IgG antibody response. As that 38 out of 77 patients had, so that 66% became antibody positive. This is the survival according to patients, whether the type of product that they received. And again, remember that half of the deaths that occurred in these were due to COVID, the other half were due to active malignancy. This is the CIBMTR data. And what, again, it shows similar to what we had seen in our single institution studies is that, it was equally divided between auto and allo, much larger group of patients. So most of the patients had a resolution, but there still was a significant amount of deaths amongst patients who received COVID, 187 out of the total, so about 10% deaths. The risk factors were obviously the same, which I think many of you have seen, is older patients. Interestingly enough, males more than females. Patients who were early after cellular therapy, less than 12 months, had worse prognosis than those that were greater than 12 months. The other factors that you see on the slide did not seem to be significant. Interestingly enough, patients with lymphoma had a higher risk of dying after an autologous, if they had achieved lymphoma patients who were autologous transplant recipients who developed COVID had a higher risk of dying than myeloma patients who developed COVID after correcting for other covariates. So the other thing that we looked at was Dr. Navas and Dr. Tamari looked at, well, we took the strategy at that time that we would delay patients in which we thought the transplant could be delayed without a problem. So 85 patients were delayed. Out of those 85, 29 never went on to receive any type of cell therapy. 16 were slated for autologous transplant, 12 for allogeneic transplants. Out of the 85, 56 went on to receive their therapy. And the reasons for not proceeding to that was development of a new comorbidity. They died from COVID or death due progressive disease. So I think one of the things that we eventually thought about it is that next time around, we would not delay, we would not have as strict a delay policy as we had at that time. And again, part of it, we did not know what the impact of COVID was going to be on our hospital, on hospital resources. One of the other things that we've developed is that in patients who had COVID, who then went on to transplant, COVID did not reoccur and their transplant outcomes were similar to patients who had never had COVID and went on to transplant. So there are two large studies now looking at the impact of vaccines and the development of immunity after vaccination therapy. These studies are ongoing and we'll hopefully see data. I can tell you personally, we have seen internally that patients will respond to the different COVID vaccines. They will, but some patients do not develop any immunity. And many of these patients are getting fourth and fifth boosts. Some of them are eventually mounting a response. So in conclusions, patients with COVID-19 after transplant have favorable outcomes, especially if in CR. Nosocomial transmission rates are very low. Delayed therapy results in patients with relapse and progressive disease not receiving their intended cellular therapy. And delaying therapy during the COVID pandemic or during the pandemic needs to be reconsidered, but it really depends on the impact on the other hospital resources. So thank you very much for your attention. I'll stop sharing. And I actually, I took an extra 10 minutes. So we have about 30 minutes for questions, answer, and discussions.
Thank you, sir. So we have Indian faculty here who may raise their hand to ask questions. Meanwhile, may I ask you one question, sir?
Yes.
As 4-drug induction has helped the high-risk disease, do you think their use in low-risk disease could significantly cure the patients or biologically cure the patients?
So that's an interesting question. And I think there's two schools of thoughts here. In patients with low-risk disease, who with 3-drug induction achieve a major response, you can say, why don't you do, we can do the CD38 monoclonal antibody post-transplant. One of the Cassiopeia study had that randomization, and it's interestingly enough, in patients who received VTD and then were randomized to Dara-Len maintenance, they did as well as those who received 4 drugs, Dara VTD, and received Dara-Len maintenance. So I think it doesn't matter. I think eventually the standard will be response-adapted therapy, that if you have a 3-drug induction, undergo a transplant, and you're still measurable residual disease positivity, standard risk or high-risk disease, you're going to get a double, another type of maintenance strategy that will include an IMiD plus either carfilzomib or an IMiD plus daratumumab. Currently, I am doing an IMiD plus daratumumab in patients with high-risk disease.
Excellent. Regarding maintenance with Dara plus Len, what's the duration of Dara?
So you do monthly Dara. I am still doing until progression. There is, in patients with standard risk disease, stage 1 MRD negativity, if after 3 years of sustained MRD negativity, we have a discussion about stopping maintenance.
Thank you. Dr.
But this is an area where we're data free now. We still don't know. I mean, this is not CML.
Dr. Meher, your question.
Sir, what is the best induction regimen in a myeloma patient presenting with pancytopenia?
That is an excellent question, Dr. Meher. So the first question is, why is that patient pancytopenic? If it's pancytopenic because of the myeloma, because the marrow is completely packed, or they pancytopenia because of immune effects for the myeloma, or they're pancytopenic because they've been, they have other comorbidities that are affecting their bone marrow. I think my first combination would be, if the renal function is normal, I would treat them with Dara, bortezomib, lenalidomide, dexamethasone. I would give them a 4-drug induction. With a lot of supportive care, they may need platelets throughout, but the idea is you need to get them to response to recover marrow function. So I would do a 4-drug induction.
Thank you. Dr. Sharath.
Thank you, Dr. Gerald, for a lovely update. So your thoughts, Professor Gerald, on isolated CNS relapse. I mean, we've seen some cases recently, even post an allo transplant. So what are your thoughts on an approach when you have CNS involvement of myeloma?
That, unfortunately, is one of the biggest challenges. And you're right, we are seeing more, Dr. Sharat, I think because patients are living longer. And in patients and I have also seen after allo transplants or CNS recurrence. So I'm actually now starting to think that a patient with myeloma who I'm taking to an allo who's beyond 3 lines of therapy, I will do a CNS check prior to transplant with CNS prophylaxis, and then do CNS prophylaxis at the 3 and 6 months post the allo, because there's nothing more depressing than, having a patient relapse in the CNS when you said I could have done something for them. And again, this is another data-free zone. The standard treatment for CNS relapse is either craniospinal radiation or intrathecal therapies with Ara-C. Thiotepa can also be given intrathecally, and it is actually a very potent drug. It's a very potent alkylator. The reality is that it's a dearth of things that we can offer. We are going to see whether the bispecifics or the CAR T can actually help these patients, but we don't know yet.
Thank you so much.
Thank you. Deepanjan.
Thank you, Dr. Gerald, for the excellent talk. My question is regarding post-transplant maintenance. What is your present approach? Like you were just mentioning about daratumumab and lenalidomide maintenance therapy in the non-transplant setting probably, but post-transplant, do you consider such approach, or do you re-stratify based on the MRD and conventional cytogenetic?
So if for the boards at this time, the maintenance therapies remains lenalidomide maintenance alone. There is data emerging that for patients with high-risk disease, a combination of lenalidomide with a proteasome inhibitor will make a difference. And that's coming from the Forte trial and other trials. So I do think that for patients with high-risk disease, double combination with a proteasome inhibitor and lenalidomide has enough data to support it. There's data emerging that the combination of daratumumab and lenalidomide maintenance may be superior than lenalidomide alone, but that data has not yet matured. in clinical practice, I would suggest that we all risk stratify patients and risk stratify based on one, has this patient high risk or standard risk disease? And if in the standard risk disease, was this patient present with stage 1 or did not present with stage 1? In a stage 1 patient who achieves a CR that's MRD negative, I think lenalidomide maintenance alone is sufficient. In a patient with high risk disease, I don't think that lenalidomide alone is sufficient. In patients with 414 translocation 1416 or deletion 17, I think lenalidomide in combination with a proteasome inhibitor is probably at this time the one with the most data. But I'll be very interested in seeing what happens with the mature daratumumab data. Now, remember, there are patients who you cannot give a proteasome inhibitor for maintenance, particularly carfilzomib in patients who have hypertension or cardiopulmonary comorbidities. So in those patients with high-risk disease, I'm doing daratumumab as maintenance. In patients who fail to achieve a major response to induction and consolidation who've never received daratumumab, I am giving them daratumumab as maintenance.
Thank you. Dr. Aditya.
Good evening, Dr. Sergio. So thanks for the excellent talk. So my question is regarding the presence of extramedullary disease in newly diagnosed multiple myeloma patients. So in your presentation, you didn't mention it as a high-risk feature of myeloma. So standard risk newly diagnosed multiple myeloma patients with extramedullary involvement, how do you treat them? Is it something different?
So that is an excellent question. I think something that there is a certain controversy within the field about whether presenting with an extramedullary disease actually is a high-risk feature in patients who otherwise have standard risk disease, meaning normal beta-2M and no high-risk cytogenetic abnormalities. My feeling is that those patients you should assess based on response. So I would treat them the same way I treat a high-risk patient. I would treat them with a 4-drug induction, high-dose melphalan consolidation, and then consider for a double maintenance. If I didn't treat them with a 4-drug induction, I treat them with a 3-drug induction, I would monitor their PET-CT. And if their PET-CT does not normalize, I would seriously consider it involved field radiation in the area of extramedullary involvement after all induction and consolidation.
Thank you.
Based on Forte trial, will you consider that in 4-drug induction for high-risk disease, Carfil must replace Velcade?
That is an excellent question, whether you should do Dara VRD versus Dara KRD. And my feeling is that it depends on which toxicity you want to deal with. So in a patient who's predisposed to neuropathy, you probably should do carfilzomib. In a patient who's predisposed to hypertension or cardiopulmonary issues, you probably should do bortezomib. Now, the problem with bortezomib is that even given subcutaneously over a period of time, a significant proportion of patients will develop neuropathy, so you have to stop it. And when I say significant, I'm meaning 5 to 7%. It's not 100%.
And for those who neither have neuropathy nor cardiac problem, will you prefer Carfil?
I think so. It's a question because there is also the question of convenience, right? The bortezomib can be given subcutaneously. Carfilzomib requires a line or requires the intravenous injection. So I think some of that depends. It's patient specific. Being agnostic, I think I would prefer carfilzomib over bortezomib.
Thank you. Yashwant, your question.
Sir, patient is COVID positive from baseline. How you treat?
So they're COVID positive at the time of diagnosis?
Yes.
So I think it depends on what the myeloma is doing, right? If the myeloma, if you can wait, I would definitely treat the COVID with, the standard COVID treatment, monoclonal antibodies, dexamethasone, and tincture of time. Once the patient becomes COVID asymptomatic, regardless of whether they're shedding COVID or not, I would treat regularly.
And dose modification if you will be using 3-drug or 4-drug, so you will be more worried for initial period of time, initial 1 month?
I think the thing with patients with COVID and myeloma, they may be shedding virus for a period of time. I think I would go with their symptoms.
Thank you. Dr. Dharma.
So I said, you nice talk. I have
Thank you. Hi.
two questions. So one is like, the people standard risk myeloma post-transplant, those who are not able to maintain even 5 milligram of LAN, will you change to bortezomib? Twice. Many people
That's
don't.
an excellent question. And I think that has, so I actually try 5 every other day of Lent to see if they can tolerate that. But in general, I have to, then I think about if I want to do some form of maintenance, I'll either do bortezomib or I'll do lenalidomide. I'll do daratumumab.
And in the high risk patient also, those who are, do you think there's a role of sometimes switching between the two LAN versus bortezomib, or giving indefinitely 2-drug combination?
I think in the high risk patients, 2-drug combination, I would not alternate though. I would give them together.
Yeah. Okay. Because
Although that's an interesting concept because because a lot of people say that they actually do not synergize that well, but I think the standard is you give them together.
Because many people develop either leukopenia or thrombocytopenia. So we say why so?
Yeah. I think when you do the combination, thrombocytopenia is the main issue sometimes.
Yeah.
Thank you. Dr. Srinath.
Good evening, Dr. Sergio. That was a very wonderful presentation. So I have a question regarding COVID vaccination. Generally, it has been noted with the multiple myeloma patient who are on monoclonal antibodies, they have low humoral response, especially post Covishield or AstraZeneca vaccine. So how do you recommend to monitor these patients, and how do you recommend extra dosage for these patients? What are your opinions about it?
So that's again, very interesting question, and one where we're a little bit data-free zone, right? What we're doing here is everybody get full vaccination is now considered the 3 doses of Moderna or Pfizer. And then in patients who fail to achieve a humoral response, we're giving them the long-acting antibody EvoShield just to protect them. Some of us have anecdotally given a 4th dose of another vaccine and seen some responses. Again, it's a data-free zone at this time. I do think, I think we forget that the most important way to address the current pandemic is adequate patient education. Remind them to A, socially distance, B, wash their hands, and C, wear a mask. And particularly important for patients who have not mounted a humoral response. Even patients who mounted a humoral response, it's important to remind them that breakthrough infections have been seen, and some breakthrough infections, particularly immune-compromised hosts who are vaccinated and boosted, can result in serious life-threatening complications. And late COVID is not a disease you want to get.
True. Thank you.
Thanks. Srijesh.
A very good evening, Professor. My question is regarding prognostication. So in your routine practice, do you use or suggest gene expression profiling or a TP53 mutation by sequencing? I'm not talking about the deletion status. For which stratification?
So we actually do not use those in our routine practice at this time. We don't do gene expression. We risk stratify using flow cytometry and regular staging. I think there is a role for gene expression profiling. I don't know how much it adds to the regular cytogenetic or FISH risk adaptation. I think some of these patients will declare themselves based on their response.
Thank you, Sujesh. Aditi?
Thank you, sir. My question is regarding high-risk smoldering myeloma based on the new 2020 criteria. Would you recommend to start treatment in these patients? And what is would you recommend to start bisphosphonates?
So what the answer is yes, I recommend that they start treatment. And B, what I've done is once you've started treatment, if the bone density is abnormal, definitely. If the bone density is normal and you're starting treatment, I would start them, but probably in an attenuated dosing. I wouldn't do every 3 months. I might do every 6 months.
Okay, sir. Thank you.
Thank you, Aditi. Ankit? Unmute.
So sorry. Thank you, sir, and good morning, Dr. Gerald. I have one question regarding the role of allogenic transplant in myeloma. So, A, what is your trigger points when you start thinking about straight away going for allogenic transplant? In what kind of conditions? And two, how do you, what is your strategy to minimize the transplant-related mortality? Because in many of the patients, the TRM is much more as compared to autologous transplant.
Oh, definitely. So let me, is there any patient in whom I would consider an allogeneic transplant upfront?
Okay.
So I'm going to tell you, I have a 35-year-old who presented with high-risk myeloma, received a 4-drug induction and autologous transplant, and is now in a BGPR, but still has abnormal plasma cells with the abnormal chromosomes. I'm encouraging that patient to go to an allogeneic transplant. Otherwise, again, in a patient who's had a short remission, particularly if they're less than 65 years of age, I'm recommending that we do some form of allogeneic transplant as part of their salvage treatment. For reasons which I have to admit I don't understand, I'm still wondering, why do patients who undergo an allogeneic transplant for myeloma have such a high relapse rate? 50% of them relapse. But there is a cure fraction for patients relapse refractory myeloma around 15%. That's 15, which is not very high. Relapse remains the most important cause of treatment failure. We have 2 research strategies for these patients that we are trying to explore. One is reduction of graft versus host disease by using our CD34 selection platform with personalized ATG and melphalan dosing. This is a study that we just started based on the data that Dr. Kone had showed that you can really reduce the risk of graft versus host disease and give everybody some form of cellular therapy, i.e. DLI, as post-transplant maintenance in combination with lenalidomide. We now have a protocol that we are exploring checkpoint blockade with ipilimumab as a way for patients with relapsed refractory myeloma. Those are patients who have failed 3 lines of treatment and again are young and relatively fit because they're getting an ablative regimen. The one thing where I know allogeneic transplant doesn't work in the patient who's rapidly progressing on multiple lines of treatment, that Hail Mary allo generally does not work. What are we doing now for the patients who is penta refractory and is young? So I have a couple of patients who are now between their 50s who have had all lines of treatment, including CAR T cells and bispecifics. So we're doing 2 what I could call interesting strategies. One is we're asking ourselves the question, why do CAR T cells not work as well in myeloma? And our hypothesis is that the lymphocytes that are being used to make CAR T cells in the patient with multiply relapsed myeloma are lymphocytes that are extensively exhausted because they've had all the treatment that these patients already have. So we hypothesized that if we could get a better starting material, the CAR T cells that we would make with that starting material would be of better quality. And there's 2 cohorts in that study. One is an allogeneic cohort. So we do an allogeneic transplant with either a CD34 selected graft or an unmanipulated graft. And 3 to 6 months later, when these patients are off immune suppressive therapy, fully engrafted, we collect their lymphocytes. But now their lymphocytes are donor derived. And we send them to BMS or to Janssen, and they make the CAR T cells. And the other one is we do a second transplant using cells the patients had previously collected during their induction. So we do a second auto. And again, we wait for 3 to 6 months until their lymphocytes counts have recovered and other toxicities of the high-dose melphalan is recovered. And we send those CAR Ts, those lymphocytes to BMS or Janssen for them to make CAR T cells. The hypothesis is that the CAR T cells made with better lymphocytes are going to work better than the CAR T cells made with lymphocytes that have been extensively treated. And hopefully next year, I'll have some data to present.
Right, sir. Thank you so much.
Great reply. Okay, Dr. Aditya.
Sir, as you discussed the master trial results, so one of the important outcomes was the the treatment de-escalation based on consecutive MRD negativity. So in your opinion, in future or in foreseeable future, so what other anti-myeloma regimens do you predict are going to offer this kind of advantage in the form of treatment de-escalation, whether it is going to be limited to the quadruplets or some triplets may also have some similar advantage?
So first, I mean, the master trial was a unique, very well done study by Dr. Costa and his group. Their high-risk patients, when they de-escalated, those patients relapsed. So they now are not de-escalating patients with high-risk disease. Their standard risk patients have all still remained in remission. But I do think that, the two things with treatment escalation, I think we have to use the CML paradigm. It's not only the time you get off treatment, which is important, but the possibility of recontrolling the disease when it reemerges. Now, one of the problems with, and he explained this, is that the way to monitor this is with a bone marrow aspirate. Now, they don't do bone marrow aspirate and biopsies, they do bone marrow aspirates alone. They do it with a very small needle because they do it with the Illinois, not with the Jamshidi, so they're not as painful. It's still, particularly in patients who are very big, bone marrow aspirations are not easy to do. It depends on the quality, but I think for your question is, treatment de-escalation will require a 4-drug induction, consolidation, and continued monitoring or MRD, at this time with the bone marrow. Whether mass spec of peripheral blood will be able to replace bone marrow aspirations is something that's being explored.
Thank you. Dr. Aruj.
I think Dr. Aruj is on mute.
Good evening, sir. Thank you very much for the wonderful talk. So I have a simple clinical scenario that we have a 66-year-old male who was not willing for transplant and has progressed on bortezomib, lenalidomide, dexa, and followed by bortezomib maintenance. Then the patient was pushed on carfilzomib single agent with dexamethasone. And after 6 cycles, he developed cardiac toxicity and the treatment was discontinued with carfilzomib. And the patient was put on daratumumab. The patient currently is doing well. He has completed 2 years of daratumumab therapy. Now, the situation is that there's monetary issue and the patient is unable to continue the daratumumab. So in this kind of setting, what would you suggest should be the further treatment choice? One. Secondly, denosuzumab or any other bone remodeling agent. What should be the duration of that bone remodeling agent? The patient currently is in complete remission.
So for the bone, let me do the bone health thing first. So the bone health, what I do is I look at the bone density. If the bone density is normal, I stop it. If the bone density is abnormal, I do it at least once a year until they want to stop. But I do it once a year. So the other question, what do you do with a patient in CR? And why is it that they don't want to go still on daratumumab?
The monetary, the financial constraints.
Okay, financial. The problem is that off treatment, he's probably going to relapse, and then it's a question of whether you'll be able to recontrol. I think it's reasonable. I think if he doesn't feel comfortable going off everything, I would think about maybe trying pomalidomide as maintenance. If he can't do that, I would consider just watching him. He's going to declare himself one way or the other.
So what would be the appropriate duration of daratumumab, if at all we could have put him on daratumumab?
The problem is we don't, the honest answer is we don't know. But there is no scenario in myeloma at this time in which continued therapy has not made a difference.
Thank you. Dr. Abhishek. Yeah. Dr. Abhishek.
Thank you, sir. Thank you, Dr. Sergio, for a very informative talk. So my question is regarding patients with renal failure going for transplant, particularly who are still on hemodialysis. So what is your policy on melphalan dose modification and any specific precaution you take during transplant of such patients?
So the standard for patients on dialysis is you dose them at 140 milligram per meter squared. Well, we are now starting and we have a clinical trial where we're doing PK-directed dosing of melphalan. We know that there is a sweet spot for melphalan that's 13 micromole per liter per minute. This was described by the Australians many years ago when we confirmed it. Dr. Gunjan Shah, who's one of our faculty member, has written about this. She's developed a population PK model where based on pre-transplant variables, you can dose the melphalan and try to get people into that sweet spot 80% of the time. We're now we're going to validate that model in a clinical trial. But what we did is we measured, we use Evomela, which is the propylene glycol-free melphalan, not Algaran. So we measured melphalan levels in more than 400 patients and developed this population PK model. We have used it outside of a clinical trial for patients with renal failure. So we basically say, okay, what do we need to give this patient to get an exposure of around 13? But in clinical practice, and if you were taking the boards in the United States, the answer is 140 milligram per meter squared.
Sure. Thank you.
Dr. Monica?
Thank you, sir. Sir, I have a question, sir, a small scenario. I just wanted to ask lenalidomide maintenance post 8 years, patient develops second malignancy B-cell ALL, sir. And he received 1 cycle hyper-CVAD, and after post hyper-CVAD, MRD was negative, but we can't take the patient for transplant. Then what will be the plan of management, sir? How common is B-cell ALL, and what is the...
Well, actually, it's interesting, B-cell ALL, but it's 8 years is a long time. Usually when we see the secondary malignancies to lenalidomide, they happen within the first 3 years. B-cell ALL is not uncommon. I mean, I have more than a handful of patients that I know of. The only way these patients achieve long-term disease control of their ALL is with an allo. If you can't take them to allo, I would treat them as a high-risk ALL and to try to get them to MRD negativity, and then probably keep them on maintenance therapy for a couple of years.
Thank you. Aditya?
Sir, what is your preferred choice for management of patients with plasma cell leukemia? Something like VDT PACE versus DARA KRD. What do you prefer and why?
I still do VDT PACE and then collect them, get them in remission, and then I do DARA KRD at the back end. I do both. And the reason why I do VDT, one is because it's what I have accustomed to. And two is I think this is, these patients are very proliferative and they respond best to the alkylators early on. But I think afterwards for consolidation and maintenance, it makes sense to use DARA KRD. Now, and the other thing with plasma cell leukemias, many of these have an 11-14 translocation. So we are using venetoclax now. If they have the 11-14, I would definitely include the 11-14 translocation. I would definitely include venetoclax.
Fine. Thank you.
Srinath?
Okay. So my question is regarding the MRD assessment. How often do you do MRD assessments for your multiple myeloma patients, and especially by which methods?
So I only assess MRD on patients who have had a VGPR or greater. And at this time, it's basically the majority of patients. So a patient who's had a VGPR or better, I do it pre-transplant at the 3-month mark and at the 1-year mark. If they're MRD negative, I repeat it at the 2nd year. If they're close to being MRD negative, I repeat it once a year to see if they convert to MRD negativity. The method we use is flow cytometry, but I think next generation sequencing and flow cytometry, NGS would probably be the one that's easiest to do across all centers.
And what is your cutoff based on this MRD levels to change your management?
Well, our method is 10 to the -6. NGS, depending on, maybe 10 to the -5 to 10 to the -6.
Okay, thank you.
Thank you. That finishes the questions from the faculty. There are a few questions from the audience if you have a couple of minutes, sir.
I do.
Okay. So what is the place of tandem transplants in the era of so many drugs?
Excellent question. I think it really depends on where you are in the world, right? If I'm in a place where I don't have access to those many drugs and I had a high-risk patient, I would do tandem transplants and then put them on some form of maintenance they could afford. Because we have all these drugs, but most people in the world don't have access to these drugs, and high-dose melphalan remains the cheapest way of treating myeloma. So I think in that regard, I think for many of the world, tandem transplant may still be very effective at treating high-risk disease. Tandem transplants in the United States have become less and less frequent but consolidation is becoming more and more frequent. So more and more people are getting post-transplant consolidation with a combination of drugs. I have, if the patient I just said, if they don't want to go to an allo transplant, I would do a tandem transplant on them.
Thank you. Those patients who have chronic kidney disease, do you end up with melphalan-induced cardiotoxicity after the transplant?
I have seen melphalan-induced cardiotoxicity. It's rare. And I don't think it has anything to do with kidney disease because it's not that you get melphalan cardiotoxicity more in patients who are on dialysis. It's rare, but when it happens, it is dramatic. It is as bad as cyclophosphamide cardiotoxicity.
If you have amyloidosis, secondary amyloidosis in a patient of myeloma, does your treatment differ?
Myeloma with amyloid, I treat the same, but I think you need to take into consideration the organ damage that the amyloid is doing. So, obviously, if they have GI, the one that I think is the most dramatic is people who have GI involvement with amyloid because they get a lot of GI toxicity from melphalan, and you just have to manage them carefully.
A patient who is relapsing at biochemical level, M-band, serum free light chain, and has no CRAB, do you start the treatment?
An indolent biochemical, so what we do is the following. A patient who has a biochemical relapse and presented with standard risk disease is a patient that you can say, well, let me watch them. A patient with a biochemical relapse who presented with high-risk disease is a patient that should be treated aggressively because that clone that's coming up is not a clone that's going to be very easy to treat as they grow more. So a patient with a biochemical relapse, I think one of the things you and the patient have to do is decide what's your threshold of treatment. I actually do is I say we change from monitoring them probably every 3 months to once a month. And then if we're seeing that it's a continued rise, I recommend that we treat. And once you treat, I think you treat to deep response. If a patient is young and your goal is to achieve long-term disease control, your goal should be, let's try to achieve a deep response. And if that means a second transplant, that should mean a second transplant.
Last question, if the patient has achieved a stringent response, but there's a residual bone disease, biopsy proven, what's your treatment? Do you give
radiation?
Radiation. Thank you. So that finishes the audience questions.
Thank you, everybody. Enjoy your evening and enjoy the rest of the weekend.
Thank you so much, sir, for doing all this for us.
Take care. Bye.
Bye, and good night to everybody from India. And thanks for our sponsors.
Thank you, sir.